In advanced kidney cancer, a number of treatments have come up within the last few years. So one of the main obstacles that we run across is that none of these treatments have been compared head-to-head. There is another problem that we don't have a whole lot of good predictive markers to determine or make our therapeutic choices based on that information. So when I'm seeing a patient, two main criteria that come into play are the patient characteristics and the tumor characteristics. So depending on how the patient looks, age, comorbid status, as well as a number of other lab tests such as LDH and calcium, and blood counts, neutrophils, and platelets, those are being considered while you're trying to make a decision of which treatment would be right for this patient. The other thing that comes into play is the patient tumor characteristics, where the metastases are, whether they are in the brain or whether there is predominantly bone metastases, which can frequently be pretty debilitating, or if there is areas where they're likely to bleed or cause compression and symptoms fairly quickly. Also, the symptomatic status of the patient and the interval from when the patient had their original diagnosis to when they present with metastatic disease is also a big factor that's taken into consideration. Currently, there are no validated molecular markers that help us with therapeutic choices in kidney cancer. A number of ones that are very interesting and are showing promising results are, the big one, of course, is PD-L1. So if there is the programmed death ligand positive on the tumor, that is a marker that tells you that the patient is more likely to respond to immune therapy, although PD-L1 negative patients also had a benefit with immune therapy. The other ones to sort of track and watch going forward, where right now they're in the research arena but are likely to come to prime time, are BAP1 mutations and PBRM1 mutations, because those have begun to show signs of being able to predict response to immune therapy or lack thereof, depending on the presence of the mutation or not. The third possible things to watch for are fairly simple, actually, like neutrophil lymphocyte ratio, as well as the time that the patient had a response on their previous anti-VEGF therapy. If you're looking at immune therapy in the second-line setting, that can sometimes be a marker, because there is a phenotype of kidney cancer, I feel, that is likely to respond and be responsive to the anti-VEGF pathway as compared to the immune therapy pathway. X4P is a CXCR4 inhibitor, and CXCR4 overexpression has been shown to play a role in the progression of kidney cancer metastases, as well as in the appearance and it's overexpressed in brain metastases. In kidney cancer, there is still an unmet need for future therapies, because not everybody is responding and going into long-term remission with all of these treatments that we have available today. X4P was developed and evaluated in kidney cancer in combination with axitinib, with the goal to look at, after immune therapy as well as VEGF TKI failures, is there a role for a third-line therapy, and whether we would get promising responses, as well as, of course, safety is one of the primary endpoints of the study. This study showed that overall the combination is tolerable. We know now the dose to use that is acceptable and feasible in metastatic kidney cancer patients, and it showed interesting and very promising signs of efficacy with response rates, as well as some that are sort of maintained long-term, even past 6 to 12 months on this treatment.